Hi, my name is Beth Williams. I am a nurse practitioner and addiction specialist. And in this mini video, we will be talking about aging women and substance use disorders. Some key topics that we'll be covering in this mini video include the burden of substance use disorders in aging women, factors that predispose women to risky substance use later in life, the impact of risky substance use and substance use disorders later in life, screening for substance use in older women, and treatment considerations for substance use disorders in aging women. I'm going to start by reviewing some of the epidemiology of substance use and use disorders in aging women. Based on a SAMHSA survey of older adults in 2022, 7.5% of women age 60 and older fit criteria for a substance use disorder in the past year, and that compares with 11.1% in the male population. In 2022, women had a lower reported use of most substances in the past year compared to men. So that includes tobacco, marijuana, alcohol, and illicit drugs. However, despite lower reported use of most substances than men, rates of opioid use disorder and opioid misuse in the past year were equal to that of men. There is a large treatment gap where fewer than 1 in 3 older women who needed or qualified for substance use disorder treatment in the past year received it. We also know that alcohol use and alcohol use disorder specifically has seen large increases among women and especially aging women in recent years. Alcohol use disorder in women over the age of 50 increased 2 times the rate of the general population, and binge drinking increased by 1% per year in recent years between 2000 and 2016. These numbers are based on a meta-analysis of U.S. national surveys. It's important to also note that the effects of alcohol can be gender-specific and different across different racial and ethnic groups. Research has identified a higher risk of social consequences and dependence on alcohol among Hispanic and Black women compared to white women, and this may have specific implications for these groups and treatment of these groups as they age. There are certain factors that increase risk of developing substance use disorders in aging women. And while not all of the factors I'm going to talk about are specific to women, they are important to have awareness of as healthcare providers as we interact with this population. So menopause and perimenopausal symptoms include anxiety, depression, poor sleep quality, and sexual dysfunction. All of these can prompt women to change their patterns of substance use. Chronic pain is more prevalent in the aging population and may prompt some women to turn to substances in order to cope with pain. Social isolation and general poor health are more common when aging and can lead to substance use. And then I think it's also important to consider the risk of worsening substance use disorder disease for those who already have or already fit criteria for a use disorder. And this is related to many factors. Social isolation and general poor health are more common when aging and can lead to substance use. It's also important to consider the risk of worsening disease for those with a substance use disorder related to multiple factors. So this includes stigmatization and mistrust of the healthcare systems that have led individuals with substance use disorders to avoid care. And so many times you're meeting or encountering an older female during their entry into the healthcare system, and they may feel a lot of stigmatization and may have avoided and need to catch up with their care needs. And then there's also been research on the high premature mortality within social networks of substance users and the implications this has for users as they age. For instance, the research on aging in individuals who use intravenous drugs has shown that they're really highly affected by the deaths and resulting social isolation that may result from high mortality among their social networks. Now we're going to review some of the risks associated with consumption of specific substances in aging women. It's related to alcohol. At any level of alcohol consumption, aging women are more at risk for the consequences of risky use. That includes falls, accidents, and cognitive decline. This is due in part to changes in body composition as we age, including a decreased total body water and a decrease in the percent of lean body mass that causes changes in alcohol metabolism. There is an increase in the severity and early onset of vasomotor symptoms, and that there is a dose-dependent relationship. So we see an increase in severity of vasomotor symptoms associated with higher levels of alcohol consumption. There's a possible association between alcohol consumption and female sexual dysfunction. There is an associated increased risk in breast cancer with alcohol consumption. There's also a relationship between alcohol consumption and osteoporotic fractures. It is a dose-dependent relationship. Alcohol has been found to actually be protective at very low levels of consumption, but then at higher levels becomes a risk factor for osteoporotic fractures. And then those diagnosed with alcohol use disorder. So we know that women with alcohol use disorder are at increased risk of depression compared with men. We know that women are at increased risk of cardiovascular and liver disease if they have alcohol use disorder compared with men. And women with alcohol use disorder are also at higher risk of sleep disturbance. Regarding opioids, there are changes in opioid metabolism that come with aging. We know that long-term chronic opioid use can result in hypogonadism, which then can cause amenorrhea, premature ovarian insufficiency or menopause, and lead to bone density changes and bone density loss in women. Tobacco has a lot of significant consequences in the aging female population. So women who are tobacco users have a 25% increased risk of coronary heart disease from cigarette smoking compared with men. Tobacco use is associated with earlier onset of menopause. Tobacco increases the risk of developing Alzheimer's disease. And we also know that women are at a higher risk of Alzheimer's disease than men. So super important to be talking to our aging female patients about the risk of Alzheimer's disease associated and tobacco as an independent risk factor for Alzheimer's disease. Tobacco may affect the benefit that women get from hormone therapy for vasomotor symptoms and make that therapy less effective. Women who use tobacco are at risk for a decrease in bone mineral density that can increase the risk of osteoporotic fractures. And then marijuana, benzodiazepines, and stimulants, each of these has specific risk factors, but we really have little evidence about the effects of these in the aging population. I think it's suffices to say that the effects on cardiovascular and mental health and cognition are amplified in aging women and important to be aware of. I think it's particularly important to highlight the prevalence of co-occurring mental health conditions and substance use disorders in aging adults. In 2021, past year suicidal ideation was much higher in Medicare beneficiaries who are, by definition, an older population with substance use disorders than without. So 24% versus 6% in those that did not have substance use disorders. So how do we tailor screening and treatment to the aging female population who healthcare providers might be less likely to consider as important to screen? I think the general approach is to screen with use of a validated tool as we would in any other population. It's important to think through how we adapt our approach to expert or diagnosis of aging women. And some things to consider include that older women may experience harmful effects of the consumption of substances at lower amounts. So we need to be sure that we're not missing a positive screen by using a higher cutoff level. Older women may be more likely to be misusing prescription medications in a way that may not necessarily fit the DSM-5 diagnostic criteria for substance use disorders, but still deserves attention and possibly intervention by a clinician in a medical visit. Some of the criteria on the DSM may feel less relevant for older adults. For instance, the item that specifies, are you using this substance in a physically hazardous situation, may not resonate as much with an older aging female who doesn't see their use as necessarily dangerous or in a dangerous context. Many older adults are retired. And so there's also an item on the diagnostic criteria that asks if their use pattern affects their ability to go to work. And so that may not be relevant. I think it's incredibly important to consider the prominent role of stigma in aging females and how they might feel to be labeled as a substance user or have a use disorder diagnosis as they age. And finally, it's important to consider screening for co-occurring conditions, including mental health and cognitive conditions, and know what you will do with a positive result on a screening tool. This slide includes a table put out by SAMHSA from the TIP 26 on treating substance use disorders in older adults. And it lays out some suggested validated screening tools for comorbid mental health conditions, including depression, anxiety, PTSD, and mild cognitive impairment. So it is our responsibility to understand and to educate women about the unique drivers of substance use as they age, and those include loneliness, pain, as we've mentioned. Sometimes just opening up the conversation with patients can help to normalize and destigmatize what can be a common condition across families and aging peer groups. Additionally, when helping aging women connect to substance use treatment, there may be barriers to access that are unique. For instance, many older adults are covered by Medicare. I know in my geographic area, a lot of the substance use treatment programs do not accept Medicare. And so it's important to know that as you're referring patients to treatment. There may be transportation barriers. I had a patient in clinic recently who told me that she would love to attend an AA or NA meeting, but most of the ones in her area were scheduled in the late afternoon or at night, and she didn't feel comfortable driving at night anymore. So thinking about just what it looks like for this patient to actually be able to attend a treatment visit. And then there may be challenges with system navigation. A lot of women in their 50s and 60s have yet to really spend much time engaging with the healthcare system, and it may come as a surprise just how complex it is, and there may be challenges to navigation. So I think using the resources that we have available to assist with that is important. So next, I'm going to cover some specific treatment recommendations related to excessive use of specific substances. So for women exposed to chronic opioids, we want to consider screening for osteoporosis starting at age 50. And that's because of the known association between chronic opioids and reduced bone mineral density. For women with opioid use disorder, consider using buprenorphine as first-line treatment for opioid use disorder over methadone. That is because methadone carries a higher risk of respiratory depression and sedation. It also has a longer half-life, and therefore metabolism is different and potentially more dangerous in older adults. Menopause and withdrawal may share symptomatology. In thinking, somebody presents to you and says, I'm having these hot flashes, or I get really sweaty at certain times of the day. I think it's important to be specific about timing of symptom onset and attempt to tease out what the fundamental cause of a symptom is. Anxiety is another symptom that is common to both withdrawal and menopause, and talking about what some of the causes may be and how to best treat it in what context is important. We know that prolonged exposure to high-dose opioids can result in amenorrhea. These women may not necessarily be older in age, but I mention it here because they may present with menopausal symptoms that are important to recognize and treat. There is a dearth of research about opioid-induced hypogonadism and how to approach and treat it. Current clinical practice is to rule out other causes and then proceed to offer hormone replacement therapy or other evidence-based treatments for menopausal symptoms and the consequences of estrogen loss, including bone density loss. We want to be encouraging smoking cessation, as this can worsen menopausal symptoms. And one thing I think that's important to highlight to patients is that even if they have been smoking most of their lives, there is still benefit to quitting. For instance, there's a reduced risk of fractures within 10 years of quitting smoking. So it's worth quitting even if it's done so at an advanced age. I wanted to point out that substance use in aging women is an under-researched area that deserves research funding and attention. For instance, there's a lack of standardization for what constitutes aging. Many studies on substance use disorders exclude participants over a certain age. There are a few studies on women who use illicit substances. So one example is that most of the research done on opioid-induced hypogonadism is based on studies from women taking chronic prescribed opioids rather than using illicit opioids. There are a few studies on care models of addiction in older populations, and we really don't know how best to approach addiction care and treatment in the aging population. Is it best done through a chronic disease or primary care lens? The evidence has yet to show us. So some key takeaways from this presentation include the fact that substance use is prevalent in aging women and may have different drivers than at earlier stages of life. Substance use and substance use disorders are associated with specific health consequences in aging females. It is important to screen for comorbid mental health disorders and cognitive decline in women with SUDs. Aging women with SUDs should be offered treatment that addresses barriers to care engagement. And finally, more research is needed on successful models of care for aging females with SUDs.